All right, good morning. Good afternoon, everybody. Welcome to this segment of our ACLS preview videos. I'm James Baker. I'm an emergency room doctor and an ACLS instructor since the mid-90s. And today we're going to be talking about the acute coronary syndrome algorithm of our ACLS classes. As usual, a little preview, a little introduction. This video segment and these series of videos are designed for our students at our medical center to preview the material before class, to give you a review of what's coming so that when you do come to class, you're a step ahead of the material, and it'll make learning during class. It just reinforces that material so that it hits home a little bit better, and you retain the information, and it makes class a little bit more smoother to get through. The material that we are taking it from is the American Heart Association 2010 guidelines for ACLS. This is the latest version, 2010. Or, show you this book as well. This is the provider handbook. Same thing, from the American Heart Association 2010 ACLS guidelines. So today we will talk about the acute coronary syndromes, and we will start out with a patient. And in our classes, if we start you out with a patient that is awake and talking, they're awake and telling you that they have chest pain, or they feel palpitations, or they feel a discomfort or a heaviness in their chest, whatever they tell you, if we start out a megacode case and they're awake and alert and talking to you, the first few things that I want the students to tell me is I want this patient on O2, IV, cardiac monitor, and vital signs. So IV, O2, monitor, vital signs. That's kind of a mantra here in our classes. Give me O2, IV, monitors, and vital signs. Okay? Once you say those things, it will unfold information so that you know what you're dealing with in the case. And you'll be able to identify the algorithm and follow through to see what we're dealing with. So O2, we're going to put the patient on O2. Now I know the latest guidelines say no O2 if their pulse ox is greater than 94%, so that's fine. But always start out your patient with O2. You can always take it off if I tell you the O2 sat is 94 or higher. Okay? So O2, IV, it's not going to hurt you in these cases to get a safety IV in place. And you can have it just with fluids at TKO or even a Heplock, but at least get your IV in. O2 IV monitors, so we're going to hook our patient up to cardiac monitors, and preferably we like the multifunctional pads that can monitor pace and shock in case we need to. So we're going to hook our patient up to the monitors, and that also includes the pulse ox monitor, of course, and then a set of vital signs. Okay? So typically while we're getting your vital signs set up, we're going to turn on our machine and we're going to show you what rhythm the patient is in. So here we see a normal sinus rhythm at a rate of 70, narrow QRS complexes. It's a regular rhythm. There's a P in front of every QRS, and I don't know if you can zero in on this monitor here, because I'm going to show you a little change with this cardiac arrest patient. And if you look at the ST segments of this cardiac patient, you can see a change that happened right there. So I'm trying to show the student ST segment elevations. You can see those there and there. So back to our patient. He's complaining of chest pain and a discomfort in his chest. It's been going on for 2 to 3 hours now. And he's awake and talking, but he's got this chest pain. We hook him up to the monitor. We see the ST segment elevations. And I'll give you our vital signs now. Blood pressure is 100/70. Heart rate is 70. He's breathing at 18. His temperature is afebrile, 98.6. And I'll tell you his pulse ox is 92%. So let's keep the O2 on him. Our vital signs seem to be relatively stable. And what big piece of data do we need for this patient that's complaining of chest pain or chest discomfort? Yes, that's correct. We need the EKG. We've got to do an EKG, a 12-lead EKG on this patient to see what we're dealing with. Is this an acute MI? Is it a STEMI? Now, chest pain patients, once we've got our IV O2 monitors and vital signs in place, we want to start treating this chest pain patient with our MONA. You remember MONA stands for morphine, oxygen, nitro, and aspirin. Not necessarily in that order, but remember MONA for chest pain patients, morphine, oxygen, nitro, and aspirin. Now, if we go up to our poster board here, and it's kind of a busy algorithm board. This is one of the busiest algorithms that American Heart has produced. But it starts off at the top, symptoms suggestive of ischemia or infarction of the heart. We're going to do our ABCs, and it's going to tell you pre-hospital, that's the green box, oxygen, aspirin, 12-lead if you can do it in the field. Come down to our blue box, this is where we're in the emergency room, and on the right it says immediate ED general treatment, and we've got our MONA listed, not exactly in MONA order. So oxygen, if the O2 sat's less than 94, we're going to give an aspirin, and remember that dose, that range, 160 to 325 milligrams of aspirin. We're going to put nitro on the patient, either a sublingual spray or the tablets or the spray, and we're going to see if that helps the chest pain. If it doesn't, then we're going to go ahead and give morphine. If the morphine IV if discomfort is not relieved by nitro. So there's our MONA interventions that we're going to start out with. We're going to go ahead and get our EKG, and in some cases EKG will take priority on these chest pain patients. We're going to want an EKG even before the O2. If we have a choice between putting the patient on an O2 or getting the EKG, remember, EKG will take priority. Once we get the EKG, we've got to interpret it, and it's going to lead us down three paths. Either number one, the EKG is normal or non-diagnostic, and if that's the case, we're going to get our enzymes, and we're going to do all of our lab works and so forth. If our EKG in the middle branch shows ST depressions or T-wave inversions that mean ischemia is going on, we're going to need to do our adjunctive treatments. Obviously, we're going to be ordering troponins and other lab tests, but we might have to do, in addition to the nitroheparin or Lovenox, Plavix, or Integralin, and admit the patient. But this is the branch we want to focus on. This is the one that's going to show, our EKG shows ST segment elevations or a new or presumably new left bundle branch block, which can be indicative of ST segment elevation. This is our STEMI. This is the big branch we're looking at. So obviously we're going to start our adjunctive therapies, heparin or Lovenox, Plavix, but we're going to be looking to reperfuse our patient. And time to onset of symptoms, if it's been less than 12 hours, then we could give fibrinolytic therapy or thrombolytic therapy. And the lower box will tell us our goal is 30 minutes or less by the time they hit the ER door to give fibrinolytic or thrombolytic therapy. But what's preferred is PCI treatment, percutaneous intervention, or cath lab. This takes priority. This is what we're aiming to do these days. This is the preferred therapy over fibrinolytic or thrombolytic treatment. So we want to make sure this patient is a cath lab patient. Okay? So, again, to recap, we've got a chest pain patient. We need to do our MONA and get an EKG fast. We need to interpret our EKG and see if we're dealing with a STEMI patient. If we are, we've got to determine onset of symptoms. If they're less than 12 hours, we need to decide, are we giving thrombolytic, fibrinolytic medicine or cath lab patient? Okay? And obviously we are going through a whole review of making sure the patient's vital signs are stable, making sure that they meet the inclusion-exclusion criteria checklist to give fibrinolytic or thrombolytic therapy, and that is in our books. There's probably 12 to 20 questions on the checklist that you need to go through to make sure they fit the inclusion and exclusion criteria. Some of the points that I'll review real quick. If you find a STEMI and it's an inferior MI, an inferior STEMI, you should ask for a right-sided set of EKG leads, a right-sided EKG. And that's going to be simply the mirror image of those leads that go on the left chest. You're going to just flip those leads over and get a right-sided EKG. Because if you get a right-sided EKG and the fourth lead on that right side, that VR4, if that ST segment is elevated, that indicates you've got a right-sided MI or an RV infarct. And if you find that, nitroglycerin is contraindicated. Do not give nitro at all if you suspect a right ventricular infarction. So oftentimes inferior MIs will extend to the right side. So if we give you an inferior MI, ask for a right-sided lead to rule out an RV infarct and avoid nitro. If you give nitro to a patient with a right-sided ventricular infarct, their blood pressure may bottom out because the right heart that's infarcting relies on the preload coming back from the body, from the inferior vena cava, to generate that blood pressure. Nitro vasodilates those preload vessels, so you're really going to bottom out the blood pressure on the patient. So no nitro in right ventricular infarcts. Morphine is also used with caution with inferior MIs and in general, because morphine vasodilates and can drop blood pressure as well. Remember, PCI treatment is the preferred treatment, and I think that covers it for the acute coronary syndromes. After you give fibrinolytic therapy, if you do that, be aware of reperfusion arrhythmias. And those pretty much, if you wait those out, they will go away on their own. They typically don't need any antiarrhythmic infusion medication. And that should cover all of our material for this acute coronary syndromes video review. Hopefully you review the other video segments that we put on and you come to class ready to go and super prepared to have a great class. Thanks for watching, and good luck studying.
We're good.
All right. Good morning. Good afternoon, everybody. I'm James Baker. I'm an emergency room physician and an ACLS instructor since 1995. And today we are going to review the ACLS algorithm for acute stroke care. As usual, the purpose of these little video segments is to provide our students at our medical center a little preview of the material before you come to ACLS class, so that you are one step ahead of the game, so that you understand the material and you're prepared for class. It'll make learning in class that much more smoother because you know the material. Smoother learning, more enjoyable learning will make the class fun, and you know our classes are all about fun. So thanks for joining us and watching this video. The material that we are reviewing is from the standard American Heart Association published guidelines for ACLS. This is the 2010, the latest guidelines that we're taking the material from. This is the little pocket book, or same thing, this is the handbook, American Heart Association 2010 handbook produced by American Heart Association. As we always say, these American Heart Association guidelines are guidelines. So in your clinical judgment, in your clinical practice, if you come across a situation that dictates that you deviate from these guidelines, go right ahead and do so. These are simply guidelines to allow a structure for you to follow. But if a situation comes up where you need to change or do something different other than the guidelines, that's perfectly fine. Go ahead and do it. Rely on your own clinical judgment and decision making. Okay, so today we're talking about acute stroke care and the acute stroke algorithm. We're going to give you a case here, and typically when we start out with cases for megacode in our classes, if we start you out with a patient that's awake and alert and talking, we want you to ask for 4 basic things at the very start of the case: O2, IV, cardiac monitors, and vital signs. Okay? IV O2 monitor vital signs, IV O2 monitor vital signs. You ask for those things and it will start the case rolling. We'll provide you with information, data that you can use so that you know what algorithm you're in and follow along the algorithm. So our patient, we're going to start out with our patient. We'll call him Mr. Jones. He's a 70-year-old patient. He comes in complaining of feeling weak. And that's all he tells us, he's feeling weak. So we're going to put him on O2, get an IV in, put him on our monitors, and get some vital signs started. So we're going to pretend to hook him up, and our monitor shows what looks like an irregular rhythm, narrow QRS complex, rate is in the 90s, 100, kind of fluctuates, but we don't see any P waves, and that irregularity shows us or tells us that this is AFib or atrial fibrillation that we're dealing with. So we might want to confirm with the patient, do you have a history of atrial fibrillation? And he'll say, yes, I do, but I never take my medication. I never take my Coumadin or my anticoagulants. So this is one clue, because AFib, patients can be predisposed to forming clots and throwing clots, which can produce stroke. So if we reassess our patient and ask a few other questions, a little bit more in detail, well, sir, show me your face and smile for me. And if he's got a drooped face, that's one indicator of a possible stroke. If we ask him to speak for us, is he speaking clearly? Can he recite back to us? You can't teach an old dog new tricks, and if he's slurring his words and can't get the words out, that's a second basic indicator that he could be having a stroke. Third thing is motor weakness. If we ask him to put his outstretched arms out, and if he's weak on one side and all of this is new, that's a third indicator that he's possibly having a stroke. The stroke scale that the American Heart Association likes to use is the Cincinnati stroke scale, and it will test those three things I just went over: facial droop, slurred speech, and weakness, one arm or one side of the body. If a patient has only one of those three signs, the chances that he's having a stroke is 72%. Okay? So it's high likelihood that this patient with AFib has thrown a clot and they've got a stroke. The next question we need to ask is, when did these symptoms start? What is the onset of symptoms? Because we're looking for a time window where we can treat this patient and reverse his stroke. For typical strokes, it's 3 hours or less. For most patients, or many patients, that time window has now been expanded to 4.5 hours or less. So if he meets that time window, we can possibly treat him with the fibrinolytic or thrombolytic therapy, the medication called TPA. All right? So let's go through our poster, our algorithm produced by the American Heart Association. And starting at the top, identify signs and symptoms of possible stroke. So that's going to be our Cincinnati pre-hospital stroke scale of slurred speech, facial droop, or one-sided weakness. The green box represents EMS or pre-hospital care, so obviously support ABCs, give oxygen if the oxygen is less than 94%, do our stroke assessment, establish time of onset of symptoms, alert the hospital, triage to a stroke center, and check an Acute check as well. Check the sugar level, because patients that are diabetic, if they have a low blood sugar, sometimes that can masquerade or show us signs that could be mistaken for stroke. So check for hypoglycemia, and if you find it, give sugar and see if those symptoms go away. Another point I want to make is triage to stroke center. So a typical situation would be if the patient is going to go to a hospital and their CT scanner is down or malfunctioning, then the correct maneuver by the paramedics would be to divert that patient to another hospital that has a CT scanner capable of performing and doing a CT scan on the stroke patient. Okay, so that's what they mean by triage to a stroke center or a hospital that has CT capability. We go down to the next box. The patient arrives to the emergency room. Check our ABCs, our vital signs, do our O2 IV monitors. do an Acute check, perform our quick neurologic screening assessment, which is our Cincinnati stroke scale, alert our stroke team, and get our patient to CT scan or MRI fast. Okay? And once we get our patient to CT and back, we should have a reading of 30 minutes or less for that CT scan. Okay? Perform our neurologic assessment by stroke team or designation, review the history, review the time of onset of symptoms, do our NIHSS scale, and get our CT scan results back. In the first few hours after an acute stroke, our CT scan should be normal. CTs do not show any abnormality in the first few hours of stroke. So if there is an abnormal reading or blood or hemorrhage, like this branch of the algorithm shows us, then our patient is disqualified from meeting the stroke criteria of fibrinolytic or thrombolytic therapy. If our CT scan does not show hemorrhage and is otherwise normal, then our patient has an acute ischemic stroke and we need to consider fibrinolytic therapy. So we need to go through our book, our checklist, inclusion, exclusion criteria, make sure our patient meets those, and following our repeat neurologic exams. If our symptoms improve suddenly and go back to normal, then we would term this patient a TIA, or transient ischemic attack, and we would not give this patient fibrinolytic therapy. If our patient remains a candidate for fibrinolytic therapy, then we've got to review the risk and benefits with the patient and family of giving fibrinolytic therapy. Our fibrinolytic therapy is going to be TPA or RTPA, and if we do give TPA, the patient is not to have any anticoagulants or antiplatelet treatment for the next 24 hours. Now, sometimes patients will come in and they'll say, well, I've been on aspirin. Is that okay? Am I still a candidate to give TPA? And the answer is yes. You can certainly still give TPA to those patients. Just do not continue to give them aspirin or any kind of blood thinners after you've given them the TPA. Okay? Few other things, tips to go through. Remember the difference between ischemic stroke and hemorrhagic stroke, as it listed on the poster. These patients that are candidates for TPA fibrinolytic therapy, they should be showing ischemic stroke, meaning the blood vessel got blocked or narrowed and there's no blood flow, but there is no hemorrhage, there is no bleeding in the brain. There are 8 Ds of stroke care. You don't need to know all the 8 Ds, just remember that they do exist, from dispatch to detection to drug to door to disposition. Remember, fibrinolytic therapy can be given within 3 hours of the onset of symptoms for most patients, and that window is expanded to 4.5 hours for many patients. Which patients, oftentimes we're asked, which patients does the 4.5 hour time window not apply to? Which patients cannot get fibrinolytic therapy if they're in the 3 hour to 4.5 hour time range? And the exclusion criteria for those patients are any patient older than 80 years old, any patient that has a severe stroke scale, an NIHSS scale of 25 or greater, if a patient has been taking any kind of oral anticoagulant, irregardless of their INR reading, or if the patient has had a history of both diabetes and a prior ischemic stroke in the past. Those 4 criteria remove the patient from consideration of getting TPA. Otherwise, all the patients that meet the criteria in our checkbook should be able to get TPA therapy. Okay? Back to supplying oxygen. Patients that have a pulse ox of greater than 94 should not get supplemental oxygen, so no O2 for those patients. Always remember to do an Acute check to make sure you rule out hypoglycemia in these patients, which low blood sugar can mask strokes or misleadingly cause stroke symptoms in patients. Make sure you use your Cincinnati pre-hospital scale of facial droop, slurred speech, or one-sided motor weakness. Make sure you are constantly monitoring the ABCs on these patients, airway, breathing, circulation, IVs, monitors, vital signs. And two are vital signs. If our patient is going to be a candidate for fibrinolytic therapy, they need to have a blood pressure of less than 185 over 110. So if the instructor tells you your patient's blood pressure is 190 over 120, you've got to lower that blood pressure under 185 over 110 before you give them the fibrinolytic thrombolytic TPA therapy. And you can use labetalol, you can use hydralazine, you can even do some nitroglycerin in order to lower their blood pressure under 185 over 110 so that they're a fibrinolytic candidate. Sometimes we're asked, well, what's the risk of giving TPA? Certainly that's a super blood thinner. Is there some risk of bleeding? And the answer is yes. And the main risk is the risk of cerebral hemorrhage, bleeding in the brain. That risk is about 5%. So you need to make sure that the patient and their family are aware. Yes, probably 30% of the time we can have success in reversing a stroke and improving the signs and symptoms of stroke, but it comes with a 5% risk of inducing cerebral hemorrhage. So you have to make sure you know that number and make sure the patient and their family are aware. We talked about repeating neurologic outcomes, repeating neurologic exams to make sure the patient isn't deteriorating or rapidly improving, because if they rapidly improve, you may not want to give the fibrinolytic therapy and induce that risk. And then finally, make sure if EMS pre-hospital is calling, make sure your CT scan is working. If it's not, then the answer is to tell them to divert to a stroke center or a hospital that has CT scan capability. And then finally, you want to make sure, this is kind of a post-resuscitation after you give the fibrinolytic therapy, you want to make sure you ask and do a final rundown of the ABCs, make sure your vital signs are stable, make sure you get a post-case EKG, X-ray, lab work, everything you can think of at the end of the case. Just make sure you ask for the case and ask for the results. Make sure there's no other information you need to act on. And with that, I think that concludes this segment of acute coronary syndromes review for our ACLS classes at our medical center. And you know who you are. So thank you for watching. Make sure you watch the other video segments of ACLS class review so that you come to class prepared and ready to go. Thanks for watching and have a good day.